My name is Tanya Hyde, and I work for the Canadian Institute for the Relief of Pain and Disability, and I'll be moderating the webinar today. I want to welcome you to the Strategic Issues and Solutions in Workplace Mental Health webinar that we're having today with Margaret Tebbutt. And this is our first webinar in our new series on return to work, stay at work, and we're planning on having about 5 more webinars in this series through March. So we hope you'll keep an eye on our website and stay up to date on the webinars that are coming up in this series. This webinar is also made possible through the support of a direct access program through the BC government. And our presenter today is Margaret Tebbutt. She is the Senior Consultant for Workplace Initiatives with the BC Division of the Canadian Mental Health Association. She manages CMHA's annual National Bottom Line Conference on workplace mental health and delivers workshops to help managers and union leaders develop the knowledge and skills to more effectively deal with mental health issues. We're very excited to have her today, and I'm going to go ahead and hand it over.
Thanks very much, Tanya, and welcome to the people who are on the line. We will be going through the presentation fairly quickly, and I look forward to hearing your questions and discussion at the end of the webinar. So we are looking at the strategic level in terms of workplace mental health, some of the issues that are in play, as well as some possible solutions for any of us, whether we're in disability management, whether we're an HR senior person, maybe we're a health professional, and some of the things that we can do to improve both our workplaces at the organizational level as well as improve the situation and outcomes for individuals. So what we're talking today about is at the Mental Health Works presentation, although it's been adapted. Mental Health Works is an initiative of the Canadian Mental Health Association based in Ontario, but available from coast to coast to coast. And I'll be giving you some websites where you can access many of these resources at the end of the presentation. So some of our objectives when we're talking about workplace initiatives are both at the individual level. How can we help individuals be successful and well at work? So individual well-being and ability and disability management, as well as organizational psychosocial health and safety. So those are the things that we can do much more upstream, both in a prevention mode as well as in a health promotion mode. And at the broader macroeconomic level, what can we do to encourage participation in the workforce by all Canadians, no matter what our health condition, as well as productivity when we are in the workforce? We know from the Conference Board of Canada's research that common mental disorders actually engender a loss of almost $21 billion per year in labor market participation, which, if you take the obverse of that, indicates potential gains for our economy as well as participation in the labor market if there are efforts made not only by government but also, and most importantly when we're talking about the workforce, by employers at their own level. A report that came out just a couple of weeks ago from Towers Watson, their Staying at Work survey report, looked at individual well-being and the effect of both physical and psychological illnesses. But what I found particularly interesting is the emphasis that they put on what are the things at the organizational level that can have an effect. And we know that the economy's been going through tough times over the last couple of years, and most businesses, most workplaces have had to do more with less, resulting in many cases, an excessive workload for the people who are there, long hours in many cases, and that factor in particular was found to cause almost 90% of the sources of chronic stress, followed by lack of work-life balance, which makes sense when you're working long hours or have excessive workload, as well as unclear job expectations or conflicting job expectations when we're all under the gun and trying to do a lot. Not quite as important, but still up there, was the effect of technology. Now, technology can be our friend, but when it expands the expectation of our availability for work outside of working hours, it can be a stressor. So those are some of the sources of chronic stress. Some of the effects are certainly stress-related, both physical and psychological illnesses. So that's when you're looking at ability disability management. But also from a broader business perspective, if you're in HR or you're thinking about your business and you really want to keep your top performing employees, number one reason for all employees, but in particular top performing employees to leave their current employer are those sources of chronic stress that we highlight up above. So there's a business reason for paying attention to this. When we talk about money issues as well as how many people are affected, again, Towers-Watson found that in Canada, pretty close to 85% of both long-term and short-term disability claims were related to mental health issues, either as a primary or as a secondary cause. So, and that's been trending upward. What some people forget about when they calculate their costs of absenteeism, sometimes we neglect paying attention to the costs of presenteeism. And Dr. Kessler out of Harvard did a study some years ago looking at that. When common mental disorders, in particular depression, are not treated or are inadequately treated, our ability to function at work, even though we know we need to be there, the team depends on us, but we're not able to be as productive due to difficulty focusing or concentrating or getting along well with others, other coworkers or customers, can have an important effect, even greater effect on our productivity than absenteeism. And when we talk about how common mental illness is and how common it is for employees in a workplace to be affected by mental health issues, whether it's a diagnosed disorder or just ongoing mental health issues, almost half of Canadian employees were found to have experienced that, and that was based on a large study done by the Conference Board of Canada last year. So, broad impact. We know that 1 in 5 of us experiences a mental health issue or addiction issue every year. And whereas with many other health conditions, the impact, the episodes, the symptomology tends to happen later in our life, be it cardiovascular or cancers, for example. With mental health disorders, we often have our first episodes in our younger years, between ages of 18 and 65, which of course is the age of most of the working force. Unfortunately, whereas if we're having stomach pains or a broken arm, we would go and seek medical attention, because of stigma or because of difficulties accessing help, many of us don't get the help we need. But, so that's a big issue. In terms of solutions, there's good research that shows, just as with many other health conditions, the earlier there's proper diagnosis and the earlier there's effective, adequate treatment, it correlates to a reduction in the time lost to disability and the frequency and the severity of our symptoms. So it's good for the individual. It's also good for the workforce, for the employer. And Carolyn Diwa found through a study she did last year that there's early identification and effective treatment correlates to improving the probability of returning not just to adequate levels of productivity, but high levels of productivity. So that kind of destroys the myth out there that once we've had depression or bipolar disorder or anxiety disorders, we'll never be able to be productive again at the same levels. In fact, provided we get the diagnosis and effective treatment, we can. Going back to Towers-Watson, so what's in it for businesses? Why should businesses invest in this? Well, there is a return on investment for companies. Almost 2/3 of companies that do have highly effective health and productivity programs are found to perform better than their competitors. And what do we mean by highly effective programs? Well, the top three things to do are, first of all, commit to saying health and its impact has an impact on our business. And we're acknowledging this high up in our value statements, in our goals for our business. So that commitment at the leadership level is number one. Secondly, having managers and leaders, operational managers, actually be role models in their behavior for healthful lifestyles. So whether it's going to the gym or it's modeling healthy lifestyles from a mental health promotion perspective. And thirdly, focusing not just on physical health, but equitably on mental health as well. So those of you who may be at the organizational level in terms of HR or workplace wellness, these are some things to take to your leaders meeting in terms of ways your company, your employer, can be effective. We also know for some time there are human rights laws that require not discriminating in employment based on a medical disability. So there can be not only legal cases, but that headline in the local paper that one never wants to see. And more, and those of you in BC will be familiar with Bill 14, which amends the workers' compensation legislation here in British Columbia so that, and I'm shortening this a little bit, not to go into all the legal aspects, so that diagnosed mental disorders which have a causation of relationship to the workplace can be compensable under workers' compensation in British Columbia. So that's the compensation side. In addition, there's currently a draft policy out and expected to come out later this fall to bring in occupational health and safety policies which will have the effect of law as related to workplace psychological safety and health, with a particular emphasis on what employers need to do as related to bullying and harassment. So more and more legal requirements on employers. So think about yourself. Think about your own workplace. Think about yourself as an employer. As an employer when one of your staff is experiencing mental health issues, or the staff member is off sick with mental health problems, and when the person returns to work, are these people treated the same as people off work or coming back to work after cancer or a heart attack? What are your policies and processes upstream so that you are promoting your own workplace as a psychologically safe but also a psychologically healthy workplace? And many of you will know that new voluntary national standard is coming out from the Canadian Standards Association and the Quebec equivalent, and my understanding is that is going to be published in November of this year. And that will help provide some guidance to many employers in terms of what are the factors around psychological safety and health, and what are the processes to pay attention to that. We also know that the Mental Health Commission of Canada, in its broad national strategy that was published in May of this year, really paid attention not only to mental health from the broad public health perspective, but also paid attention to the workplace. And the Commission called on senior executives, both in the public and private sectors, to create workplaces that are as mentally healthy as possible. And in terms of how to do that, well, in the action item, let's look at implementing the psychological health and safety standard, but also look at comprehensive approaches to mentally healthy workplaces. I think we've done pretty well in many cases at learning how to do the stay at work or return to work at the individual level. How can we bring it up to the more comprehensive organizational level? All the research that I've read and the various reports that have come out that look at how can mental health in the workplace be improved tend to come down in terms of one of the top action items being operational frontline management training. Why? Because that's the person who interacts on a day-to-day basis with an employee, with a person, with a member, if it's a unionized environment. The Conference Board report from June of last year found a real disconnect that a large majority of managers do feel comfortable or think they feel comfortable discussing mental health issues with staff, yet only a quarter of employees surveyed think that their manager is effective. And what becomes troubling is 3/4 of the managers would treat a sudden change in the employee's behavior either as a performance management, so a discipline kind of approach, or just sort of, we'll wait and see what happens. And only 1/5 would actually discuss the issue with the employee and direct them to resources, be it simple as their employee assistance plan or to their health plan. So there's a disconnect there. And managers also said in the survey, we really need and we want training because, you know, we're not therapists, we're not diagnosticians, we shouldn't be, we're not counselors. We need to know what is our legal duty here. I'm not a therapist, how do I handle this difficult conversation? And I know my job as a manager is to keep this place productive, that's my job as a manager. And part of my job is helping the employee to be both productive and well, and more broadly, including creating inclusive workplaces. So what we do in our Mental Health Works training for managers and union reps is help them understand, you know, these are complex issues and we don't have simple solutions, but hopefully gives them clarity. What can they do to help employees be both productive and well, but also manage the coworkers on the team and their perceptions of what's fair, what's equitable, and also maintain their own mental health. We know that managers are often at risk because they've got demands from above, demands from below. So all these things that managers are responsible for. So the strategy we propose when we're doing this training is basically 3 steps for the manager or the union rep. Noticing changes in behavior without jumping to assumptions or conclusions. Secondly, entering into a conversation that expresses concern about the performance, but also about the person's well-being. And then thirdly, focusing on solutions that work in a collaborative manner that's focuses on solutions rather than rehashing the problem, and keeping it workplace-based. It's not the manager's job to solve the person's family issues or personal issues when they're the operational manager. So when we talk about noticing, I know there's a number of health professionals on this webinar, and for you, you know the Diagnostic and Statistical Manual and you're familiar with all the different disorders. When we're thinking about the frontline operational manager, it's important that they know that there are different kinds of mental illnesses, but they do not need to know what the diagnosis is if they're the operational manager, for 3 really important reasons. First of all, if they had a number of employees, all with clinical depression, the behaviors that are symptomatic of depression that are affecting that person's functioning in the workplace could be very different. Some employees might be tearful. Others, and I've had major depression, and I know when I was in the workplace before getting treated, I was irritable, and that came out as snapping at my employees, at being sharp and arguing with them. So another common behavior. Some of us with depression will withdraw socially and isolate ourselves from our staff and our coworkers, and that can be a problem for productivity. And some of us, and I did this one too, get to work, cry for 15 minutes in the car, put my face back together, put my professional mask on, go into the workplace thinking nobody can tell. So very different behaviors that affect the workplace, all various symptoms of the same kind of illness. Second reason, we know that it often takes a long time for the specialist to come to the correct diagnosis, and there may be more than one diagnosis going on at the same time. And thirdly, the most important reason for the workplace, if we're walking around with this label on our forehead, you know, he's bipolar, she's schizophrenic, it's just like walking around with the label of our ethnic origin or our gender identity or the number of letters behind our name on our business card. We're not paying attention to the whole person. Now, it is important for operational managers to know this employee has a health condition that's affecting their ability to function at work, and therefore there's a duty to accommodate, and we're going to put these things in place. They don't need to know more than that. Even though as a good manager, you know, I think if I just knew, I would research it, I could help the employee, but may not be the case. We also know, of course, that addictions are illnesses and often co-occur with mental illnesses, often begin as learned behavior from childhood. And just as with many other mental disorders, one of the symptoms is often lack of insight that we are in fact ill. So how do we help non-clinical specialists, operational managers understand what we're talking about with mental health? We start thinking of making the analogy with a balance ball, three-dimensional and even four-dimensional if you think about time. So it's nice to be in total balance every day at work. There are times when our energy is pumping, the adrenaline's pumping, and we're really productive at work, but we have a relaxing weekend, come back to balance. We may be at work and our high energy is not just one day, but every day, and I look like the most productive person in the workplace. I'm taking this project on, volunteering for that, I've got all of these ideas, and I look really productive, but my judgment may not be as good as when I'm in balance. And of course, if the high energy goes on day after day, night after night, we may be losing touch with reality, and our ability to function is impaired. And that's what's important in the workplace. I don't know about you, but sometimes I come to work and I've got low energy. But I'm at work, rest on the weekend, come back to balance. We may be in the workplace and that low energy is every day. And we're getting through our work, getting through our tasks, but it's much harder. And at the end of the day, we're so exhausted that it's hard to do anything else in our life. And we just may not be as, getting to things as well as when we're in balance. And that's affecting the workplace. And of course, with major depression, our ability to function is impaired, and just getting out of bed is a challenge some days. We all have worries or fears, and it may be interfering a little bit in our productivity as we're thinking about what was my teenager doing on the weekend. It's normal. Come back to balance. We may be having anxiety and we're waking up at 2 o'clock, 3 o'clock in the morning worrying about that report to our director. We may be waking up at all hours of the night wondering about, should I have used 8-point font or 12-point font, or, is the Excel spreadsheet looking really nice, and we're worried about minor things, and we can't function, we can't get our job done, our life requirements done. We can all be distracted or withdraw. We can, in fact, have hallucinations or dissociation if we've gone without sleep for over 72 hours, and we may get to the point of impaired function. And the thing for people in the workplace who aren't clinicians is to understand that we can have different levels of any of these situations. We can have combinations of them, the anxiety and the depression, or the high energy and the dissociation kind of things, or the anxiety. And we help people understand, well, you know, in terms of what causes this, to understand there's lots of research going on. We know a lot more now about brain chemicals and changes in the brain. Don't really know what comes first just yet, but we do know what are risk factors, one of which is genetics, of course. Another one is experiencing or being either being a victim or observer of a single traumatic incident or ongoing trauma at lower levels. Personal stress can be a risk factor. Maybe we've just taken a mortgage on a house and the house prices are going down, and we've got elders who are ill and teenagers acting out, etc., etc. Can be a risk factor. And more we know that workplace stress can be a risk factor. And we help people understand that, you know, we all say our workplace is so stressed. What we really mean is there a balance or imbalance between the demands of our job, the control over we have over those demands, and whether or not there's social support within the workplace. And these are just risk factors. They're not necessarily causative. We can have all of those and still never develop a mental illness, or seem to have none of them and still develop a mental illness. One of the big issues around mental health in the workplace is that there are lots of assumptions made. That this person just has a bad attitude, or is a slacker, or not a team player. And we're human beings. We try to figure things out. So those assumptions can be harmful. A lot of assumptions when a person returns to work after being on sick leave due to mental health issues, that everybody, both that person and coworker, forgives and forgets. And I may not have been the most pleasant person before I went off on sick leave due to the symptomology of my illness. I may not, my symptoms may have improved, but I might not be back up to the same level of performance and cognitive capability just yet. Maybe I have some resentments as to how I was treated, the names I was called, and some assumptions that I now have good coping strategies. May not be there quite yet, but it's still good for me to be returning to work, helpful. So when we think about the average workplace, you know, we say, well, why doesn't the supervisor just talk to the person? Why doesn't the person just talk to their boss? It can be hard because supervisors are really busy people. They've got deadlines to meet. They don't want to invade somebody's privacy. They don't want to get accused of harassment. Maybe they're not comfortable with somebody yelling at them when they raise an issue, or crying. That would be even worse. So it can be hard for supervisors to feel comfortable or have the skills to address this. And employees may rightly fear being fired, or maybe not fired, but their position is made redundant. Maybe they'll lose respect. And as we know, when we have a mental illness, before we understand what's going on, we often don't understand it. Think it's just everybody else's fault, and you know, I ought to be able to get over it. So these conversations can be challenging for the operational manager and the employee in a workplace. So what we suggest is, starting off as a supervisor or as a shop steward, I'm concerned about your well-being. I've noticed changes in performance in terms of your behavior, and I'm concerned about you as well as the performance. So again, think about your own workplace. When somebody returns to work after cancer, are there pink balloons and you're a survivor? What about somebody returning to work after being off with depression? Do they get a silent treatment, or are they welcomed? And if it's the latter, you know, maybe look at how you might improve things in your own workplace. Some of the ways we suggest is try to give people simple words. You know, when somebody's off work, sometimes we say, well, nobody can talk to them, you know, until they actually come back. Only insurance or only HR can talk to them. Well, sometimes we feel really isolated and betrayed when there's no contact. And it can be simply sending a thinking of you card. And when appropriate, we're preparing for your successful return to work. When somebody does return to work, at least say, welcome back. It's good to have you back. And this is what we've been up to while you've been away, maybe on an individual basis or as a team environment. And when somebody is struggling at work, you know, just, I'm wondering what's going on, and I'm concerned about you. And I know we've got some resources. Maybe I can help. So moving on then to the solutions at work, there was an excellent report done by Drs. Renee Louise Franche and Georgia Pomaki with the Occupational Health and Safety Agency for Healthcare a couple of years ago in terms of best practices. And you can see the top 5 here. And as I said, at the end, I'm going to give you a website where you can find this in more detail. But you see the approach in terms of broad-based, systematic, organizational-wide initiatives that are key to this. So when we're talking, again, at the organizational level, what are the elements of psychological safety and health? It's really about how people interact in the workplace, how management practices are structured and working conditions are, and how decisions are made. It's about prevention of harm. This is standard occupational health and safety language, prevention of harm, but also promotion of psychological well-being. So what affects our mental health at work? I'm sure many of you are familiar with the work of Robert Karasek and Segrist, Terrell, and others. So there are some risk factors that can affect our mental health. We've talked about work overload, pace, the demand control balance or imbalance, and perceived unfairness. So there's unfairness, but there's also the perception of unfairness that can be a risk factor. But there are also some really important protective factors for our mental health, that sense that self-efficacy, I can control what happens, or if I can't control what happens, I can control how I react to the changes. Social support is a huge protective factor. Social support from the supervisor, the co-workers, the union members can be really protective, even when there's high demand and low control. And the standard will be looking at what are some of the strategies to increase protective factors and reduce risk factors. So the big question comes down to how can I, whatever my role is, frontline manager, HR, union rep, maybe disability case manager, how can I help you to be successful at work? Because it is the worker who has the responsibility and the ability to be successful in their job. We do know that work can be good for our health, provided the workplace is a healthy workplace. It gives us a routine to our day, and if we're dealing with anxiety or depression, maybe that can help structure our day. We may be isolating ourselves if we're dealing with depression, and at least there's some social contact in the workplace. Working can give us some positive activity to our day, and it also is part of our identity and gives us a sense of purpose. And sometimes people forget, you know, work also gives us a paycheck. It's really important for our sense of psychological security to have that financial security. We know that unions can play a very important role, both in terms of the individual, understanding how this whole accommodation process works. It can be very overwhelming when you're into it. But also at the organizational level, working with management to, okay, how can we help this particular worker? And at the organizational level, making sure that the workplace is respectful and that there is not bullying and harassment in that workplace. So how do we get there at the individual level? This could be the return to work case manager, but I would also suggest that it's really important that the frontline supervisor be involved in this, along with the worker. Those are the people that are going to be working together for the 8 hours or 10 hours of the shift, and they know what the work is, what the job is. So it really flows back and forth between these three areas. What do you need from the workplace to be successful in your job? But also for your contribution as the employee towards your success at work, what will you commit to? And the third area is often the tougher area. How do you want for future workplace issues to be addressed? And that's the interpersonal stuff that was probably existing before the illness and was treated and will be in place afterwards. So in terms of what you need, it's really looking from a strengths-based approach. Not so much the problems or the problems or the dysfunctionality, but what are your strengths? What are you looking forward to? What are you excited about doing? And it's important to be really specific when we talk about flexibility. What does that really mean on a day-to-day basis? Graduated return is pretty straightforward, but how do you want instructions to be given to you? How can we communicate on a day-to-day basis if you're dealing with short-term, memory problems or difficulty concentrating? What are our solutions to that? But also, what are you willing to commit to? So it's making sure that the employee takes both the control and the responsibility for their well-being at work, and moving back to the previous level of productivity to the extent possible. So, what do you need to do? What will you commit to do in terms of self-care? Maybe it's actually taking my lunch break. And maybe that can be something the supervisor can help with, ensuring that people do take the lunch break, because I'm so anxious to show that I can be productive that I may be working through my breaks. And that's how we may feel with the anxiety. The future workplace issues, if there's a plan up front so that if my symptoms start to return, or if I'm feeling emotional, or if the supervisor's getting irritated, how are we going to deal with that? And we've got a plan in terms of recognizing this could come up, and we know how we're going to deal with it. So this is another version. This is a more linear version of that. What do you need? What will you commit to? And how do you want future workplace issues to be addressed? And of course, this is an area where, there's lots of case law under human rights law, arbitration cases, and now with compensation law changing, it's really important to recognize that there are some situations that are much more complex, and it's important to bring HR in, and if necessary, legal counsel. So think about what you might do differently following this webinar, both in your professional role, but also in your workplace as an employer, as a manager, maybe as a union rep. I did promise that we would bring up some places where there are resources that are accessible. So the first one is the Bottom Line Conference, which is coming up at the end of February. That's really going to focus on the new national standard. But in the meantime, there are lots of resources available online for free from that website, and many of the reports and research reports you can access through that website. Here in British Columbia, we have a number of workshops that we're offering in Vancouver and Kelowna, and you can go to that website and see when they are. We've got some workshops focusing on Bill 14, and as a matter of fact, called Safe and Sound. The Mental Health Works program has a lot of great resources online that you can access for free, as well as some that have a minimal charge, and there are instructor-led workshops offered across Canada on a fee-for-service basis. The Canadian Mental Health Association has about 120 branches across Canada, and many of those branches, the larger ones, offer services such as vocational counseling, supported employment, and access to employment opportunities. So for people dealing with mental health issues. So you may be able to partner with the local Canadian Mental Health Association branch in your area. We've just introduced a new skills training course that's based on cognitive behavioral training. So it's not counseling, it's not group counseling, it's building life skills, and it's based on the work of a psychiatrist from Scotland that's been well researched, well proven to be effective. And of course from the Canadian Mental Health Association website nationally, as well as each region, a lot of information around mental health, mental illnesses, treatments, etc., all available through those websites. So Canadian Mental Health Association is a registered charity. Some people think we're a government organization, but no, we are a charity, and rely on the support from individuals as well as organizations. Again, this is my contact information as well as the website for Mental Health Works. And we're just coming up to the end of the presentation. I'm looking forward to hearing your questions and hearing from your comments. Thank you very much.
All right. Thank you very much, Margaret. That was a very wonderful presentation. There were a few things in there that I was unaware of as well, so that's very good. I'm noticing now that we actually don't have any questions that have been submitted yet, so if you have a question that you would like to address to Margaret, please feel free to type it out in the question box on your panel and submit it, and I will read it to Margaret for you. And then if we don't have any that are submitted in the next couple of minutes, we might end the webinar. So let's see if we get any questions.
I know we've gone over this very, very quickly, and I'm sure there are some issues or comments or people may be thinking about.
Oh, I was also wondering, Margaret, I have had a couple of people ask about will the PowerPoints be available? They won't be available afterwards, is that correct?
No, and unfortunately these are copyright to Canadian Mental Health Association, but my contact information is accessible as well as those websites, and I'd be delighted to talk to people in more detail.
Perfect.
Or just go to those websites for some of the information.
Great. That's what I thought, so I just wanted to confirm. We did get a question. You mentioned case law. Is that referring as well to employers' obligation to accommodate needs, in particular special needs of employees?
Well, there's a lot of case law, and I'm not a lawyer, so just need to point that out, but a lot of case law, whether it's around duty to accommodate, there's a lot of case law around that, and cases that have gone all the way to the Supreme Court of Canada. I'm sure there's going to be case law coming out of the, in the future, coming out of some of the workers' compensation. There's case law around disability benefits, so lots of case law. Certainly one of the great sources of information on that are the Lancaster House publications and conferences.
Great.
For those people who want to get right into the legal aspects in the case decisions.
Great. And then we have another question. Oh, one person was wondering if you can go back one slide so that your email is displayed again. Perfect. Yes. Also, someone asked, what sort of advice can you give to healthcare professionals when they are negotiating return to work with an HR manager? Is there specific language used to help the employer understand needs of the employee but maintain confidentiality?
Yeah, could you repeat that, Tanya? I didn't hear the first part.
Oh, I'm sorry. What sort of advice can you give to healthcare professionals when they are negotiating return to work with an HR manager? And is there specific language that they can use but still maintain confidentiality?
I think the most important language to use is language that's around the person's functions. So their ability to function as related to their job. So there'll be areas in terms of a functional capability that are strengths, where the person does have those functions. So as well as areas where they're still recovering their ability to function. So much less around the clinical aspects as around the operational functionality. So for example, it might be around ability to concentrate, maybe in terms of interaction with other people. The person's quite able and keen on interacting by email or various computer media, but is not at the present time able to deal with people face-to-face for a long period of time. So maybe the person can deal with queries that come in their job over computer but not face-to-face. Or the opposite. Maybe they're having troubles, focusing on the computer but are able to deal with people on a face-to-face basis. So focusing on functionality as related to the person's job with a emphasis on their strengths.
Great. Let's see, what else do I have? Someone says, I had a colleague who was off on mental health leave for unknown reasons. She has chosen not to share her reasons for her leave for over 7 months and cut off all her means of communication with the team. Do you have any appropriate strategies to engage with this certain colleague?
Well, I think sometimes we do that when we're off, when we're experiencing mental health issues such as depression. We sometimes do cut ourselves off from other people. I think we start with the premise that, yes, this person will be returning to work at some point. And if you're the operational manager or the HR person, maybe just keep it light initially, keep it simple, a simple email or a simple card just saying we're thinking of you. The person doesn't have to reply, if you get the thinking of you card, but at least you're reaching out to the person. Maybe if you're having a holiday event at the workplace, invite the person if he or she wishes to come and attend with no expectations around returning to work just yet, but just reaching out, keeping that contact, and when it's appropriate, maybe it's not you in your own workplace, but through HR, starting to start the communication around the return to work when the person's well enough.
Very good. And then another one, someone asked to reach out to rural/remote citizens with supports is a challenge. How can a program like LLTF work with that population?
Well, for example, the Living Life to the Full program, there are some certified facilitators who are based in various areas of BC already, and they're starting to train people in Ontario. In the meantime, the booklets that are part of that Living Life to the Full are available through the website. So and we've got a lot of people who've ordered them for themselves to read through. They're pretty easy read. Some people, in some cases, psychologists or therapists have ordered them to use with their clinical patients.
That's very good.
So yes, I understand it's not as available. There is another program that's also based on Dr. Chris Williams' work that's more of a phone-based coaching service, and that's available throughout BC. It's not outside of BC yet. So again, based on cognitive behavioral therapy, and that's based on a referral from the family physician. So it's not when a person has major depression or bipolar disorder or anxiety. It's sort of low levels, mild perhaps, mild anxiety, mild depression, and the physician remains the responsible care provider but a bounce back coach, the program is called Bounce Back. The bounce back coach who works for Canadian Mental Health Association is supervised by psychologists, works through material over the phone with the person. This is a free service that when you're talking about remote, as long as you've got a phone line, the program is accessible.
Very good. That's a great resource. And I'll make sure to also post some of these resources that you're discussing here on our blog post as well. So that will be available to people. And then another question, as a union rep, how could I approach the direct supervisors on how their past interactions were negatively perceived by the employees? And would it be a good idea to tell them about some of the websites you gave us?
This raises all sorts of issues. I think at a broad level, I think it's really good when you have, for example, it might be one way of approaching this might be through your joint occupational health and safety committee and raising the issue of psychological health and safety and the new requirements in BC as well as the new national standard at that broader level in terms of how anybody in a supervisory role or in a union role within your workplace might best behave so that you're creating a psychologically healthy workplace. So that's at the broader level. I think when you're talking about at the individual level, I think it might be helpful, you know, when a person's doing the stay at work or return to work plan, that third aspect, the interpersonal interactions, that the conversation actually include the employee as well. Perhaps you as a union rep can be there along with the manager, maybe HR as well. And so it goes through, you know, what are the things that may be difficult, and maybe you can help that employee raise those kind of behaviors, but also perhaps some of the behaviors of the employee in terms of how the employee will commit to behave within that workplace.
All right, that's very good. And then I think we have one more. How do we deal with employees who do not want to communicate the reason why they cannot work before 10 a.m. due to medical condition and do not want to cooperate with the to provide the employer supportive functional limitations to support accommodation? So essentially, how do you work with employees who don't necessarily want to work with you to get accommodation?
Well, I think if the employee is asking for accommodation, first of all, there needs to be, you know, a reason, whether it's any of the grounds under human rights law for accommodation. So in this case, if there is in fact a medical disability that for which they're asking for accommodation, it may be that they need to have the doctor's certificate. And I'm saying not in every case, but in many cases they will need a doctor's certificate that there is a medical condition that's affecting their ability to function. Then you go back to, okay, you have this. How can I help you be successful at work? So if the person is saying, well, due to my medical condition, it's really difficult to get to work by 10 a.m., then you have that discussion, well, this is the nature of work, and maybe you work it out that, yes, that person cannot start before 10 a.m., but will work later in the day. And I guess it depends on the nature of that particular workplace. Or works fewer hours, but that means the hours that aren't worked are you know, either taken as sick leave or not paid. But also perhaps looking at, okay, what can you do? Are there ways that you can be at work earlier? How long is this going to be going on for? So for example, if I remember one case which was a library, and the person was dealing with, the manager said the person was dealing with seasonal affective disorder, having troubles getting to work. It happened to be shift work. And this person said, would it be okay if I took the afternoon evening shift? And that worked really, really well in that particular case, because most of the other employees did not want to work that afternoon shift. But again, it wasn't going to be on an ongoing basis. It was going to be for a particular period of time.
Very good. That's some very good strategies. I think that we will call it there. Thank you very much, everyone, for attending and for being present at the webinar. Thank you very much to Margaret for her presentation.
It was my pleasure.
Thank you.